Livestream. We are here, it is Wednesday night, it is 8:30. My name is Kane Treble, and that means, of course, we are here to smash the KFP exam by practicing a bunch of questions together. Hopefully you've all had a great week so far. Say hello in the chat, let me know who you are. But of course, we need to focus on the point we are all here, and that is the fact that we are... mucking up the inputs again. There we go. Let's try that times 2. There we go. We are 58 days from the 2024.1 KFP exam. So we really do need to be getting our butts into gear. We need to be focusing in and making sure this is probably our biggest priority at the moment. So just under 2 months, hopefully you are feeling like you are set and ready. Obviously, at this point in time, the more questions you practice, the more you refine your technique, the better chances you have of getting through the exam. So I wanted to spend a little bit of time, again, as we do at the start of each of these live streams, going through some of the tips that I know mucked me up on some of my initial approaches, and hopefully aren't things that you're going to experience yourself. So, of course, one of the things is to make sure that you're avoiding repetition. And by that, I mean don't just regurgitate information from the STEM. Feedback from almost every KFP exam report shows that they just don't want you to be repeating the information that's provided in the STEM there, and that's a common thing they see again and again and again. So if the STEM mentions a management option that is already used, don't include it as part of your management plan. And if you do specify what you would do differently, that's not already been done, so you are differentiating it in some way, shape or form. Similarly, if the patient's smoking status isn't mentioned, it's likely that they don't want you to specify smoking cessation in management options, but it might be part of questions or further aspects of history that you might need to answer. Similarly, if a patient presents complaining of central crushing, non-radiating chest pain, and we're asked what aspects of history would suggest a more sinister cause, answering the quality of the chest pain isn't going to get you any marks because that's already been provided there. Responses asking for the quantity or severity of pain would, because that hasn't actually been already given. Sometimes you might be thinking that the same response could apply to multiple questions in the same case. And again, this usually hints that you're not answering the specific question being asked. You never want to be reusing the same response or answer within a case. Look at which question that response best suits, and then try to think of another response for any other questions. So use your context clues there. Of course, we also have a bunch of fallbacks, and probably the thing I wanted to focus on tonight was what to do for those mind blank situations where you are staring at the page and thinking, oh boy, I have no idea what kind of approach I want to take here. What are the kind of structured approaches you can fall back onto that might help you save a few marks where otherwise you would miss out? So for starting off with diagnostic type questions, always try and think in the frame of what's an acute diagnosis, what's the big red flag thing that I don't want to miss here, what's a more subacute thing but potentially needing urgent or immediate intervention, versus what are the chronic diagnoses that can present in this way as well. Often taking that little bit of a framework can just help you flesh out a couple of potential options. Now, another mnemonic that I highly, highly recommend everyone memorise, and yes, memorise, this is one of those ones that if you put at the top of every page on your note paper, it'll serve you well. Vitamins A, B, C, D, E. Some of you may remember it from good old medical school days, or you may have used it in other studies, but I think it's a really good thing to give you that broad list of differentials to fall back to. So vascular or heme causes, infective or post-infective causes, trauma, autoimmune or allergy, metabolic, and that can include things like lipids, proteins, carbs, or micronutrient deficiencies as well. Idiopathic or iatrogenic causes, neoplasia, malignancy, social, which can include things such as abuse or deprivation. Alcohol, substance and smoking kind of get lumped all together. Behavioural or psychological causes, congenital or genetic causes, degenerative, and of course endocrine or exocrine causes. If you can think of even one or two examples from any of these kinds of categories, you can see you're going to very quickly build up a rather broad array of potential diagnoses to consider. For our management questions, again, try and have that acute and chronic kind of approach. And you'll find, in particular for the questions that are based in emergency departments or rural emergency departments, they really want you to focus in on that DRS, ABCD, EFG kind of approach. So it's that dangers, response, sending for help, which could be nurse, other doctors in there, sometimes ambulance, escalating for transfer to a different facility. Or inpatient referral to subspecialty as well. Airway, breathing, circulation, which is usually insert large bore cannulas, start IV fluids, bloods, those kinds of things. Disability, so starting to bring in a little bit of a GCS score or AVPU score. Exposure, making sure that you identify and manage any things that are picked up through there. It's a couple of things that are not specifically part of the usual mnemonic, but F here is fast the patient. So if there's any kind of surgical consideration, specifying that you're going to fast the patient is usually good for a free mark. And of course, don't ever forget the glucose, the thing we always forget. Coming into chronic management questions, try and break these into our pharmacological or non-pharmacological causes. And there's always been a little bit of debate about where oxygen fits into this. And so I think you could potentially put it into either category. I think as long as you're thinking of things like supplemental oxygen, you're on the right track. Of course, medications will come into play. And again, to specify that doses are not required unless specifically requested. And I think it's pretty few and far between that you'll have it actually be requested there. It's probably going to be some of your big ticket items that they really want to hammer home. You need to know. That's things like your intramuscular adrenaline doses for anaphylaxis. Immunisations, man, the college loves immunisation questions. Don't know why. But yeah, you need to know it. And remember to include as well your ATSI populations in terms of what specific immunisations they may be eligible for. Non-pharmacological options, we have a lot of things here, and this is our care plans, health assessments, SNAPs, so smoking, nutrition, alcohol, physical activity, always good for free marks. Referrals through to physiotherapy, occupational therapy, psychologists, dietitians, and try and think as well of what kind of conditions or situational support services might be applicable to this. So one of the questions that does come not infrequently is things around domestic abuse and what kind of support services might be available for people in that position. Always think as well about legal advice. We'll talk a bit more about this in a little while. But in a rule of thumb, it's patients to a lawyer, doctors to medical indemnity. And of course, housing and living assistance, whether anything needs to be done in that situation. And always remember the RACGP handy book, which is absolutely chock full of awesome tips and tricks to try out. Now, if you have some of those questions that aren't really diagnosis, aren't really management, sometimes we get those more free-form kind of questions. I try to take a biological, psychological, sociological, and legal kind of approach to this. So the biological is what anatomical or physiological processes could be involved, what interventions could target these. The psychological is tying in what impact it is on the patient's mental health, and with that really you're going to be tying into screening, things like K12, DAS21, EDEQ for eating disorders, and ASRS for things like ADHD. Now of course then who would best engage with this condition? And never forget to start off with the basic things like family, friends, drug and alcohol counselling services, social workers, psychologists, psychiatrists, and don't forget to specify that you can always schedule a follow-up appointment with GP. Always be mindful to throw into there 4X. So anytime you're referring, anytime you're organising a follow-up appointment, always get that extra mark that's always available by specifying why you're doing that. In terms of the sociological approach, what specific sociological impact is there? And try and focus in on it. So usually it's going to be something along the lines of a loss of income or income protection. And so talking through options there as well. All right. Now, of course, the legal. Everyone loves legal, of course. We all read about it in our spare time. I know I don't. So does the patient or situation require legal advice? And for that matter, do you? Because if the patient's talking about legal things, you probably need to be covering bases as well. So in your case, it is going to be usually the medical indemnity provider and the analogy I always use here is if the plane's going down, put your own mask on first, as well as talking to your practice manager and peers within the practice as well, or practice principals. Patient, really, they're talking to a lawyer. Tied into that kind of legal framework as well, you should be looking into, are there any advanced care directives, and if they need to, appointing any medical treatment decision makers, which are the new term for medical powers of attorney. In terms of that sociological aspect here, if there is that legal concern on a broader scale, then it should be escalated to places like the Healthcare Complaints Commission or APRA, the Australian Health Practitioner Regulation Agency. And yes, we need to be spelling that out to try and avoid any abbreviations, not being too mindful of particular spelling as long as you're getting the basic gist of where you're trying to get them. They've said time and time again that that will be more than sufficient. All right, so we do have some practice questions here tonight. We'll start off on case number 1. If you have any questions about any of the tips and tricks we've just covered, pop them into here. Something I will also be saying at the start of each of these questions, sometimes I do notice answers coming through later on for earlier questions, so always try and make sure that you're actually up to date in the stream, that if you click the little red icon down the bottom, you can drag that all the way to the end and you're actually at where we're up to in here, because we do occasionally get people answering questions from the start of their live stream at the end of the live stream, which is fine. So, case number 1, let's get 2 minutes on the clock, and of course, our time starts now. I really love it when the automation starts playing up again. Right. That's all right. We will crack on to the answers here. I thought I had these bugs squashed after last week's live stream. Bear with me. That's okay. We'll get through. So, hopefully we've got some answers there. Cases like this, I've actually seen essentially exactly this case several times. And what we have here is a question about, well, why is this person iron deficient? And anytime we have iron deficiency, always think, is there enough iron going in? Is the iron going in able to be absorbed? And is there something that's burning through the iron stores faster than it should be? And so really there it's poor dietary iron intake. Now, far be it from me to presume that a 19-year-old university student may not have the greatest diet. That's fine. Of course, we are looking here at what is likely going to be a inflammatory bowel condition, and so there could be poor absorption through the bowel. And of course, if there is inflammatory bowel disease and blood loss through intestinal bleeding, we could be looking at that as a blood loss source, which will again burn through whatever iron stores are there. I've always found in real life, it's usually a combination of all these things together that contribute to iron deficiency, so always be hesitant to ever put down one single reason as to why someone's iron deficient unless it's very, very, very obvious. All right. Of course, we have another question lined up. Let's put 2 minutes on the clock, hopefully, and your time starts now. All right, so hopefully you are happy with your answers. Now, iron infusion is one of those things that we will often refer for. Where I'm working, we actually are working in a GP clinic within a hospital, so we do our own iron infusions managed on the ward or day procedure unit. And so this is one thing that I think we really should know, even if you're not actually giving the iron infusions, you should be able to discuss with the patient what are the risks involved. So generally, very, very safe. They happen all the time in Australia, but things can go wrong. And of course, like all medications, anaphylaxis is potential, even if they've had previous iron infusions that they've tolerated without incident. In particular, because it's an intravenous infusion, the risk for anaphylaxis is quite high if it does occur, but we still manage it just as we would any other case of anaphylaxis. The most important step, of course, is to stop the infusion. Now, the next most common things that people will actually experience and are definitely worth mentioning to patients is headache and sometimes a sense of dizziness as well that kind of tie together a bit. So I'd kind of lump those together as one single answer there. And similarly, things like abdominal pain, nausea, vomiting, constipation or diarrhea, really it's gastrointestinal side effects. So just as people often experience these kinds of things when taking oral iron, some people still get those same effects when taking an iron infusion, so worth warning the patient about. Flushing is particularly common. In particular, a very warm, kind of unpleasant sensation of flushing, which is often alleviated just by slowing down the infusion. Tachycardia, also quite common, and hyper or hypotension. The blood pressure can go up or down, and again, slowing down the infusion tends to settle that down as well. Bronchospasm can be present as well. And the one thing that I think we are particularly good at warning people about is the risk of skin staining. So if the cannula isn't properly inserted and the iron does extravasate, leave the vein, go underneath the skin, it can actually stain the skin permanently like a tattoo, and that can last forever. You can try similar kind of laser tattoo removal techniques, but it doesn't tend to be overly effective. So always worth warning, especially when it's, say, a young female that is particularly concerned about things like that. Now, you can get muscle spasms and pain as well, which can be for quite some time after the infusion, so worth mentioning to patients. And that ties in a little bit to the next thing, which is hypophosphatemia, which is something that probably is explained to patients. There is a fairly profound risk of hypophosphatemia that can require admission and has unfortunately led to patients becoming very sick and even a few deaths as well. So making sure that you've actually checked phosphate levels, if need be, supplement in the short term, and keep an eye on them for a little while after as well. Any symptoms, be sure to check phosphate levels and supplement accordingly. Good summary in ETG about that as well. If you want to warn them about what to look out for, it's a bit of irritability. They can have paresthesias, muscle weaknesses, all the way through to hemolytic anemia, delirium, seizures, and arrhythmia as well. So can be pretty nasty. All right. Of course, we have more questions on the way. So let's get 2 minutes back on the clock for our final question for case number 1, and your time starts now. All right, time is up, and again, just make sure you're up to the time for the next question as well. This rash, oh boy, this is one of the few times where you may experience anal flutter. This is one of those terrifying diagnoses. This is, of course, Stevens-Johnson syndrome. So, to make sure you would actually get all 3 marks available for this question, you need to specify that you're calling 000 for an urgent ambulance transfer to the emergency department for suspected Stevens-Johnson syndrome. If you're specifying that you're calling for an emergency ambulance, that it is an urgent transfer you're requesting, and suspected Stevens-Johnson syndrome, you're going to get all those marks there. If you were to just say ambulance transfer to ED for suspected Stevens-Johnson syndrome, I think you'd be missing out on that mark. They do like you, even though it's kind of implied by the fact you're calling for an ambulance. They like you to actually specify urgent. Likewise, if you just say ambulance to transfer to the emergency department, yeah, you're going to get a mark, but you're not showing that refined consultant level knowledge that they're really trying to hunt for here. So you haven't specified urgent, you haven't specified why you're sending someone or why you're making that referral there. Now, Stevens-Johnson syndrome is absolutely terrifying. There's not a whole lot we can do other than that supportive management, keeping that patient in a very controlled environment, obviously stopping the offending medication. And this is a pretty classic situation where it's within the first 2 months of starting a medication. Can be any medication, but azathioprine is one that's known to be associated with Stevens-Johnson, and of course trying to maintain skin integrity as best as you can. All right. Of course, we have more cases. We have more questions. The night is young, and I am not. So let's put 2 minutes on the clock, and your time starts now. All right. So this is one of those cases where they already know that you almost certainly know the answer to what is the diagnosis. And so they'll often come out and specify this is, toe fascious gout. What they want to know here is why. And so what they're really asking is what are the risk factors for toe fascious gout, or gout in general, really. And of course, he has increased age, genetic predisposition, pure-in-rich diet, alcohol use, diuretic or hydrochlorothiazide use, and here it doesn't specify that he has diabetes at all, and so I don't think you'd actually get any marks for that there. Where this gets a bit vague is that there's no obvious genetic history here. There is some evidence to say some Asian populations can be at increased risk compared to other populations, but it's one of those things you do have to make some presumptions. And what's frustrating is they don't always let you know which assumptions are safe to make and which times they're saying, oh, well, we didn't put that in the STEM. You've actually given us made-up information. Sometimes you've just got to try and go with your gut there and work out what you think is going to be that right answer. And this is, of course, where practice, going through these questions again and again is going to be the best way to work out what is the right or most appropriate answer in this case. And so here, I think you'd be pretty safe by putting down most of those things there, but I'd say the diabetes risk is probably a bit too risky in this circumstance. All right, now let's get to question number 2. We'll put 2 minutes on the clock and your time starts now. All right, so 2 minutes is up. Let's get to the answers here. This is, I think, a pretty standard question in terms of what's going to be the best bang for buck in terms of actually confirming the diagnosis here. Clinically, we've already pretty much made up our mind, but it is good to rule out any other pseudo-gout or other monoarthropathies. And so here, things like a joint aspiration, you could actually send off to check if we have negative or positive bifringent crystals, would be appropriate. Serum uric acid levels would be absolutely fantastic in terms of actually checking what is that, and you'd be able to use that as well to try and work on suppressing that. And of course, X-ray of the left foot, to actually check the joint space and see if there's any other kind of erosions or destruction of the bone that may actually point you in a different direction or different, diagnosis. So hopefully you've got some things there. Now the joint aspiration here I think would be worth more marks, because this is really going to be that gold standard test for confirming the diagnosis, actually getting those crystals under a microscope to confirm exactly what you're dealing with. All right, let's move on then. So we'll get to question 3, case number 2. 2 minutes on the clock, and your time starts now. Oh, this is one of those questions they love, because everyone falls for their dastardly little trap of saying, oh, yep, we'll give them an NSAID, we'll give them ibuprofen, good pain relief, and yes, usually recommended for patients with gout. But this patient's on candesartan and hydrochlorothiazide, so using an NSAID in this case would be the triple whammy and would result in a 0 for the question. Now, of course, one thing here that you would be specifying is cease hydrochlorothiazide. And in that instance, it may actually be that they could consider giving you a mark, but I think that would be on a case-by-case basis. Of course, things you could try would be a local corticosteroid injection into that joint space, oral prednisolone. Again, dosing's not specified, but one of those handy ones to know. The recommendations now are 15 to 30 milligrams oral daily. Of course, ceasing that hydrochlorothiazide, and allopurinol would not be indicated in the acute setting. You always wait for that acute exacerbation to settle down before commencing your lowering agents. So hopefully you didn't use an NSAID here. Of course, we have another question. So let's put 2 minutes on the clock, making sure as well that you are as far to the right on the slider as possible to make sure you're on time, and your time starts now. All right, 2 minutes is up, and let's get to some answers here. And so great to see a couple of answers coming through. And yes, everyone looking at this is saying, yeah, it's probably going to be migraine with aura. So very, very well done. And of course, we do have here benign intracranial hypertension. If you're starting to get symptoms like this, I do fear you're leaving the benign component of that diagnosis, but something you could potentially consider. I don't know how it would go in terms of getting some points here, though. And intracranial lesions, yeah, true. Definitely would be something to be taken into consideration here. Now, of course, the migraine with aura is going to be that 2-mark answer here, and tied into that, which are separate diagnoses, would be things like retinal migraine or ocular migraine. Retinal migraine is the more unilateral form. Ocular can be both eyes as well. Migraine being less specific, remember we want to be specific and concise. You're going to get 1 mark, but you're going to be missing out on that 2-mark option there. Occipital lobe epilepsy can present similarly to this as well, and so it would be something that if standard treatments are ineffective or there's failure to response, you would have to be considering. And of course, transient ischemic attack. I have seen a patient who presented very similar to this that turned out she actually had a patent foramen ovale and subsequently needed to have that managed because she was actually having TIAs. So try and keep that kind of broad mindset. And yes, I will fully credit intracranial lesions would definitely get you a mark in here as well. So well done. Of course, let's get to the next question. We'll put 2 minutes on the clock and your time starts now. All right, time is up and let's get to the answers. So we do have lots of options here, and one of the things I always want to highlight with these questions here, anytime you see migraine and the oral contraceptive pill, one of the options is always going to be cease the oral contraceptive pill. They want to kind of highlight that you've actually got that marked there. Of course, using an antiemetic given the patient's complaining of nausea would be appropriate, and the go-to for migraines usually metoclopramide, so again, be high marks there. Now, tying in then would be our kind of NSAID or anti-inflammatory medications, so aspirin, ibuprofen. They would be grouped, so you'd only get marks for one, not both. Paracetamol, simple analgesia, fantastic, but they have specifically mentioned here that previous simple pain relief has been ineffective, and this means we can actually move on to our triptans as well, and as long as you're giving a sensible option for a triptan, you're going to get those marks there. Now, I will highlight here that if there is nausea involved, sumatriptan's a fantastic option because you can give it orally or you can give it intranasally, as has been pointed out rather successfully there by John Travolta. Great to have you here tonight. Dance the night away. And so it would be something that I would be considering for this patient in particular. I will just pop into here. You have specified an antiemetic with an example. I would probably say, instead of saying antiemetic with an example, or as you have here, NSAIDs, e.g. diclofenac, I would actually just take out the NSAIDs, e.g., and just specify diclofenac. Again, these are clinicians that are marking the exam, and so they do have that understanding of, well, you've acknowledged that kind of branch by putting that answer, and so you would get that mark. Hope that makes sense. All right, let's move on to the next question then. We'll put 2 minutes on the clock, and your time starts now. All right, so time is up, and let's have a look at what the answers coming through are. Now, you'll actually see this kind of stuff all the time in the exam where the third question seems to depart a little bit, but I want to highlight here, this is actually already giving you that hint there. I thought she was on the oral contraceptive pill. This should be flagging, oh, did I forget to do something? And this is where you can actually make marks by going back and saying, oh, that's right, there was the pharmacology thing I could add into there, cease the oral contraceptive pill. So just a little tip there. Of course, this is using the UK Met guidelines where we have lots of options here. Many of them have been specified in your answer, so very well done. So we have the copper intrauterine device, the levonorgestrel intrauterine device, the Implanon subcutaneous device, depot medroxyprogesterone, progesterone-only pill, and you would not get marks for, again, using the COCP, given obviously we have migraine with aura here, or the NuvaRing vaginal ring device. And looking into this a bit further, there is conflicting evidence, well, there's really a lack of evidence to say the NuvaRing isn't a fantastic option, but after there were some cases with bad outcomes for patients, the manufacturer has actually stated that it should not be used in patients with migraine with aura. So that tends to end all debate on that matter. Now, if I want to get really, really nitpicky on the answer there, I will say avoid abbreviations. So you've got IUD and LNG as well. In the exam, make sure you do spell it out, and I appreciate you're probably just putting down the abbreviations to get the answers in tonight. I would say practice, practice, practice. Make every time you practice answering these questions, try to do it as if you would do it on the exam day. And I know it sounds stupid, but it'll stop you on the day from making silly mistakes and using abbreviations where even if your answer is 100% correct, they might be subtracting marks or not giving you marks rather because you've used that abbreviation there. So just save yourself the heartache, save yourself the pain, practice as if it's the actual thing. Fantastic. Now, of course, that is the end of the cases for tonight. Well done for getting through them all. Hopefully you found this useful at all. And of course, if you do, I'm going to keep doing this every week on Wednesdays at 8:30 p.m. before the exam. So come back, join us again, spread the word, tell other people if you think this could be helpful for them. And of course, I'm always keen to try and make sure I'm actually being as useful as I can to candidates sitting the exam. So if you have anything in particular that you would want more information on, if you want more practice questions of a certain type, pop it in the chat here, pop it in the comments if you're watching any replays, and I'll try and get back to it and try and tease some things out and get some things set up there. I remember how frustrating it was when I sat trying to get through, and I now that I've passed, I wish I had these kinds of resources available to me back then. So so that I'm making the best use of my time, giving you the best use of your time as well, feel free to let me know what you actually want and I'll try and do what I can. Cool. All right, so that is pretty much all I have prepared for tonight. If you do have any questions, feel free to chuck them into the chat now. Otherwise, I'll be gearing up and looking forward to catching you all again on next Wednesday night. We'll be 1 week closer to the exam, which can be terrifying. Some things that you really should be implementing now, if you're not doing it already, actually look at calendar blocking. So making sure you're dedicating some time each week, at least one session, preferably two, to just going through practice questions and making sure your techniques are correct. Often it isn't our clinical knowledge that lets us down for the KFP exam. Really, the AKT exam assesses your clinical knowledge. The KFP really is the style of answering and knowing how to answer these questions. So the more you practice, the more you're aware of the traps and pitfalls, that's when you're going to find yourself prepared for this exam and getting through. So, of course, a pleasure to be with you all tonight. I'm getting old, so I might call it here, and I will look forward to seeing you all next week. So have a great night, enjoy the rest of the week, feel free to post any questions, comments or anything down below, and I'll see you all next time.